just politics, so there's something else at work. In those polls I mentioned this morning, more than half of all Americans said that they were confused and disappointed with the legislation and really couldn't explain why in lots of cases. And you know, who's to blame for that, and what can we all do about that? And public policy sector, the news media, to what degree are they responsible or not responsible, and what can the various stakeholders do? So I'm going to introduce the panelists as I ask them the first question. Then I hope they're going to mix it up, and they are not shy, and then we'll throw it open to everybody. So I want to start with Charles Rothenberg. Charlie, you want to raise your hand? And if you don't mind, I'm going to be pretty informal and use everybody's first names, unless anybody objects. Charlie is a board-certified ophthalmologist who has spent most of his professional career treating patients on Long Island. But for our purposes, and the reason he's on this panel, he is currently commissioner of the Medical Society of New York's Governmental Affairs Division, which has jurisdiction over the medical society's lobbying and public health activities, including healthcare reform. So Charlie, do you want to tell us from a doctor perspective, okay? What are the things that doctors feel are very good about this, and what are they worried about?
Well, first I want to thank you for including me on this panel. When you ask me to tell you what doctors think, or what the medical society thinks, it's representative of the divided nature that the population has over the healthcare bill. I was on the executive committee during the year that health systems reform was enacted in the Medical Society of the state of New York, and as Dr. Davis alluded to, some state societies revolted against the AMA position, and I think that the AMA position was not as strenuous as you might think, and that some of the states didn't support the bill strenuously. I would tell you that New York State came perilously close to not supporting the AMA position, based on my experience there. And the reason is that I think it's very hard to bring all of the positions under the umbrella that Dr. Berwick suggests that we have to stay the course. And that is because there are competing practice models, there's different competing interests that different specialists have, and there's different competing interests based on your geography.
What are the doctors most worried about?
I think the doctors are worried about they're going to lose their autonomy and their ability to advocate on behalf of their patients. I think if you look at the provisions of the bill, you see policymakers who I think are wise, but generally their models fall short. We've had a 30-year experiment with managed care, which has not achieved its stated objectives. And we heard the phrase this morning about top-down policy. I think that most industries would like to see something from the ground up as well. My feeling, and I think the feeling of organized medicine, is that by policymakers having top-down drivers of healthcare policy, you're squandering a tremendous resource, and that's the innovation that is in the brain trust of the physician.
Charlie, be specific. When you talk about worried about this top-down management and doctors losing their autonomy, give us all a couple of examples.
Well, we saw an example in the healthcare legislation of the IPAB, which is the Independent Payment Advisory Board. This is a body that will make essentially cost recommendations. While that may achieve expenditure targets, it's reminiscent of the SGR, which most policymakers, politicians, and physicians would say has been a failure. Just containing costs is not a sustainable way to bend the cost curve. You'll achieve your cost targets for this year, but you haven't changed the way care is delivered, and you haven't innovated on process. Every industry, and if you want, healthcare is an industry, it's something like 17% of our gross domestic product. Every industry innovates and makes their products better or delivers them better and shares in those efficiencies that derive. In medicine, we don't innovate because we don't ask we're not incentivizing our providers to create innovation, and when there is innovation, the providers don't share in the profit that derives from that.
So last question, and then we're going to move on. I think there's somebody in the panel already is anxious to respond.
I'm sure.
So what's the posture now of the medical society? If you're going to be lobbying, are you going to be lobbying? And the states will have a major impact on implementing this, tremendous impact. What will you be doing in terms of lobbying and legislative activity? What's on your agenda?
Well, when you speak of my agenda, I wear two hats. I represent the physicians of the state of New York, and I also represent the national physicians as a delegate to the AMA. One of the problems that we have is a lot of the benefits of the Affordable Care Act already are the law in New York State. We have community rating, we have people that are up to age 29, not just 26, that can be on the appearance insurance. A lot of the confusion, I think, is that New Yorkers aren't getting the full benefit of the Affordable Care Act, and the rest of the nation is, and we're paying for it.
We are lucky today to have on our panel another Dean of the School of Medicine and Vice President for Health Sciences at the university, and that's Norm Edelman, who was there for 10 years, 1996 to 2006. Norm is a board certified in internal medicine and pulmonary care, but he also spent a sabbatical year, I guess in 2007, at the Department of Health Policy and Management at Columbia, and developed an interest in issues relating to healthcare and demand in education. What's your response, Norm, to what Charlie just said?
It's really ironic. So American doctors have been using the autonomy issue to oppose universal health care since we started, since the 1960s. And they've been successful up until now. The irony is they maintained autonomy from the federal government, but they gave up their autonomy to the payers, to the insurance companies. You know, what doctor now doesn't have to make 10 phone calls a day to get permission to do this and permission to do that? So the whole autonomy issue is quite ironic. Our colleagues in the European social democracies were much smarter. They gave up their individual autonomy for national healthcare systems, but what they gained was group autonomy. So the British Medical Society, the Canadian Medical Association, they all play critical parts in determining how those national healthcare systems work. So I find it very ironic that we're still using the autonomy argument in this time of managed care organizations stripping doctors of their autonomy. Now I'll answer your question.
What do you worry about most, Norm? What do you like about this law, and what are you worried about?
Well, I don't want to speak about the law in general. I guess the stakeholders I represent are a very narrow group, but important group of people, and those health profession students. When you look at it globally, I think the non-medical students are pretty much oblivious. I mean, they know that the law is going to generate a huge increase in demand for their services. There's very little in the law that's going to impact on their training. There's a little bit of money for nursing in there. It's a little different for the medical students in an interesting way. The most important part of the legislation is what's not in it. So there's going to be a huge increase in demand for medical services. Medical schools are responding by opening up a lot of new medical schools and expanding medical schools, including this one. So it's been estimated by somewhere in the middle of this next 10 years, we will have more doctors graduating from American medical schools than we have places in the residency programs, unless something changes. And the Obama administration rather explicitly rejected the idea of expanding residency training, with the exception of a modest amount of money for primary care physicians in community health centers. So the medical students are worried that those who graduate in 5 years from now won't be able to choose the specialties they train in. They'll have to take what's available. Now, from a public policy point of view, that's great, because all of our good students go into primary care, and we won't have to make primary care any more attractive. But I'm not so sure the students are happy about that.
Okay. Charlie, I'll give you time later to come back and respond to that. So you should all be making notes, because we'll come back and we'll be able to respond to each other. Kevin Dahill is the president and CEO of the Nassau-Suffolk Hospital Council. Kevin, you want to just raise your hand so everybody knows you? And he, the Northern Metropolitan Hospital Association. These are two organizations, by the way, that comprise something called the Suburban Healthcare Alliance, and he serves also as executive vice president of the Healthcare Association of New York. Give us the hospital perspective on this new law. Now, what do most hospitals, first of all, you've got to start implementing some changes, but what's the position here on what are they excited about and what are they worried about?
Well, truly it is schizophrenic, to use a clinical term. Dr. Davis is absolutely correct that through our national organization, American Hospital Association, we participated in and cooperated with the negotiations over the bill and did agree to those, to that $158 billion in cuts over 10 years. I would say they're cuts. I know Dr. Davis says they're a slowing of the increase rates. I would say they're cuts. But in essence, she's absolutely correct. It's the reaction is schizophrenic, as you would expect. We haven't had wholesale state chapters dropping out of the American Hospital Association, but we've got some disgruntled hospital and health system CEOs throughout the country that think the AHA gave away way too much in this. But overall, I think because they did a good job of communicating with the field, there was an agreement that basically said we cannot not support an effort to ensure these numbers of people who are uninsured. We've been complaining about this for years, that these people are showing up at our doorsteps. And so we have to participate in and even contribute to that. Where it gets schizophrenic is all of the unknowns, because quite frankly, when the payment reform debate took place in the negotiations over this bill, Congress got very frightened because there was a lot of divide in the country. And so, as Dr. Davis said earlier, a series of pilot projects, the appropriations have been set aside for pilot projects and demonstrations that are going to roll out over the next few years around these things, ACOs and bundled payments. And there is so much unknown as to what the construct might be and what the competition might be as these things get rolled out. And there's no question about it. There's consultants getting off buses every day of the week out here, coming to hospitals, telling them they've got the latest and greatest idea for an ACO, and no regulations have been promulgated yet that even start to talk about what the parameters might be for some of these things. Except for very generally, we kind of know the minimum population. So there's a lot of fear. And the reason the fear exists is today, the hypothesis here is we want to get away from fee-for-service medicine. But the fact of the matter is that hospitals who are expected to function as businesses and therefore survive financially have to continue to survive in that environment. And they've got to create a vision for themselves of how they get from here to there, should all of this stuff happen. And that's probably going to lead to some hospital failures, quite frankly, because some institutions are going to make the leap too soon, some are going to be reluctant to make the leap, and we're going to have a lot of bumps in the road along the way. Here in New York State, who would have ever dreamed that we would see a hospital like St. Vincent's Hospital in Manhattan, a safety net provider, close? And the reason why I emphasize here in New York State is who would have ever dreamed New York State would have to allow that to happen? They had to allow it to happen because New York State is broke. And so we're entering a whole new world at a time in which we're being asked to change our very fundamental business models. And that creates a lot of fear in the hospitals.
Deal with a new business model? Is that what's really?
Yes, the uncertainty integration between hospitals and physicians and home care agencies and skilled nursing facilities. We have been meeting with attorneys from the Department of Justice over the last several weeks who speak as if this law never got passed. And they're from the federal government. They're still talking about antitrust provisions that preclude us from any meaningful business integration with our physicians and with home care agencies and so on, short of mergers and employment for physicians and so on. So there's a lot that's got to be done to clear the way to make some of these things happen.
Okay, thank you. Fred Barber. Fred represents the business community, and sometimes we don't hear the business community in the midst of all this health policy debate. As you heard Dr. Davis say, crucial in terms of getting business commitment, and they will have no choice in some respects to participate in either insuring their employees or paying a penalty. Already there have been, I guess, a bunch of waivers that have been given to McDonald's and other large companies and unions who say that they cannot meet in this first stage of the implementation for their part-time workers. They cannot meet these new regulations, and they've already gotten waivers from the Obama administration. Fred is the president and CEO of New York's Health Insurance Exchange, formerly the LIA Health Insurance. The exchange, which these exchanges are like retail shopping malls here, state by state, they are going to be key to whether this system works. The exchange is a consumer-driven health insurance product that restructures the marketplace in a competitive area and gives a lot of choice, in Fred's case, for employee choice and a choice for small businesses where they can go and insure their workers. Fred, what's the business, and when I say this, I know I'm oversimplifying because there's not unanimity in any group, but what's the business take on this new law? What do they think is good for them, and what are they worried about?
Let me answer that by giving the audience some perspective about the different businesses by size in New York State, and I'm going to go by the number of employees. First of all, there's a total of 518,000 businesses in New York State. I'm giving you Census Bureau data here. 60% of them are between 1 and 4. Dr. Davis had a slide up there showing that 46% of businesses with 9 employees only offered health insurance. Well, one of the reasons why there's only 46 is because these businesses don't have HR resources to depend upon, and they're worrying about meeting payroll. And quite frankly, health insurance is not something that they understood before PPA, CA. Now it's in the news. They know a little bit more about it. Unfortunately, what's happening is they're drawing conclusions that cause them concern, where before the ignorance, if I could call it that, the bliss, if I could call it that, or the inability to gather information, assimilate it, and understand it, had to do with their normal business obligations. Now they have this thing going on, and they don't know that there's no real employer mandate, but they do know that there's some employer penalties. They don't know that the penalties only begin for businesses above 50 employees. And by the way, 95% of all businesses in New York State are between 1 and 50 employees. So it's not inappropriate to conclude that the legislation was not rolled out in a way that the business community could understand, especially if you appreciate the fact that most businesses in this country have been driving job growth for the last 20 years. The large companies have exported jobs. It's the small businesses that really have created those jobs. And let me just finish the profile, and I'm going to give you a few comments after that. If you take the employees up to 100, that's 98.5% of all businesses in New York State. When it comes to businesses today, given their economic recession, which has really hurt them significantly, probably more so than the larger businesses, they're looking to reinvent themselves. They don't have time to engage in what this really means to them. And many of them are drawing the conclusions, quite frankly, that they can't afford health insurance, whatever that means. And they don't believe that those price points are going to be dropping. So from a business point of view, I think the administration made a bad mistake by not rolling out this legislation in a way that one can conclude would be employer-friendly and employee-friendly.
So let me just interrupt for a second. Are you saying this is a communications issue and Obama administration failed to explain it, or are you saying that you disagree with the substance of what this does in terms of business?
Well, I'm trying to answer the question about how businesses feel about the legislation.
Right, but the follow-up is, when you say that it wasn't rolled out properly. I'm trying to understand, Fred, where that...
From a communications point of view, but if you ask me
Yes.
About the substance of the legislation, I say to you the following. This is health insurance reform. This is not health care reform. The only attempt at reducing the cost of delivering health care services or improving quality is basically through the Medicare Advisory Board, which is just going to review payment reimbursement methodologies and absolutely no focus on the cost drivers for delivering health care. And a large part of that has to do with the cottage industry that makes up the healthcare delivery system in this country.
So Ruth Finkelstein, who is Vice President for Health Policy.
There are a lot of misconceptions about the legislation. I think my understanding was I was going to speak from a consumer perspective.
Yes, and you will.
It's very difficult, of course, to speak from a consumer perspective because what's clear is the health care system and the healthcare financing system is enormously complicated, and each individual's perspective is different. And so that I fully believe and understand that individual consumers are not hurt by this legislation. Many, many are helped by this legislation, potentially. What's true is people can't figure out who they are in that scenario. And it's very difficult in New York State, where in fact, many of the innovations and reforms that are positive for consumers are already in place here. And so it's very hard to point out and say, look, you will now be eligible for subsidized health insurance when you weren't before. There is a group of New Yorkers for whom that is exactly the case. Adults and kids who make more than 200% of poverty, but under 400% of poverty. But see how that doesn't ring off your lips like a slogan? You will be eligible for benefits from this legislation by virtue of the fact that how insurance is priced is going to be better. It's complicated. And consumers don't sort themselves in real life by the ways it's complicated. And so our understandings of the legislation are shaped through the prism of these stakeholders who understand very well how it's configured and are delivering messages to shape how people will understand the legislation. And right now, it's completely tied up in a very intensely politically partisan time. I can say this. When we talk about who are the stakeholders opposing, it's a political opposition at this point, and the messaging is excruciatingly gifted. And so since people don't have a visceral lived experience of my healthcare is different, the health of my community is different, my visit with my doctor is different. Instead, they have all this messaging which has political motivation, which is very effective. There was never a death panel. There was never a proposal for a death panel. And that took on a life of its own. The wonderful people at the healthcare chaplaincy who are only interested in dignity, respect, and good services for people at the end of life made this modest proposal that as people neared the end of life, that their physician would talk with them about what end-of-life care options were available to them, got shot through this distortion prism and turned into death panels, which built on people's fears. And so I feel like what consumers think and know right now is built on partisan and with interests at stake messaging rather than information they can use.
I want to talk to Jean Alessandro, who is the medical director for managed care at IPRO, an independent not-for-profit corporation committed to assessing and improving the value of healthcare services. Dr. Alessandro previously served as assistant clinical professor of emergency medicine here at Stony Brook and served as the medical director for the Stony Brook paramedic program. So welcome again.
Thank you.
Your views on what you've heard so far?
Well, I'd like to play a little bit off what Ruth was saying, because I agree that the messaging that perverted a patient empowering end-of-life discussion into a death panel is something that I found particularly heartbreaking, and that's was the impetus for having this forum in the first place, that people who are involved in public health and in the health field would be able to get the facts and be able to educate one another and the community, because I think there's a lot of credibility in the medical community as well as the public health community, and for them to be able to accurately present that message is important. But I would also like to say that as far as cost drivers go, I think that the two most important groups that are helped by this legislation are individuals with chronic conditions and women. And I think Dr. Davis mentioned both of those groups. Those are two main cost drivers, I believe, in the health field. Are individuals with chronic conditions who consume most of the resources, and preterm birth is another area, both of which will be helped by this legislation, because currently the system is engineered to exclude individuals with chronic conditions from care through rescissions, through annual limits, lifetime limits. People in the donut hole, the #1 condition is diabetes. So you have diabetics who are excluded systematically from care, when those are the individuals who would be most helped by treating their early chronic kidney disease and preventing them from being on dialysis, which is so much more costly. Similarly, women, there are 12 million women of childbearing age who are without insurance. Insuring those women and ensuring interconception care and prenatal care is the best way to reduce preterm birth.
You talk about, I talked this morning about how this is contentious and it's political, and Dr. Davis said, you know, at one level it's going on up here and it's contentious, but at another level everybody's trying to adjust. But there's not a day I don't pick up a newspaper or listen to a radio station and I get some more news about how complicated this is going to be. Jean talked about care for women and contraceptive care. Dr. Davis talked about it, and there was a story in this morning's Newsday that said that a panel of experts advising the government meets this month to begin considering what kind of preventive care for women should be covered at no cost to the patient as required under this new law. And Senator McCloskey, who's the author of the health amendment, says clear intent was to include family planning and free contraceptives for all women. That's already under attack. There are already groups emerging that say they're going to fight that on the grounds that government should not be involved in giving free contraceptive care. So it's almost impossible to separate some of the politics and some of the substance until this thing plays out. And as we said this morning, it's going to play out for another 4 or 5 years. Let's go back to talk about communication. But before we do, Charlie, any response to the idea that doctors, you know, kind of bemoan their loss of autonomy and this is a cover for kind of just blatant self-interest? Is that an overstatement?
Yes.
Okay.
Well, I'll respond to the overstatement. First, regarding the students, I don't think that I would characterize any of your students as oblivious. I have a bias here. I'm the advisor for the Medical Society State of New York to all the medical students, and the chapter here at Stony Brook is one of the most robust and has the highest penetration. They had 104 new members last year. You should be proud of that. I don't know if an applause is worth that, but a lot of the people there are participating in this event. And your question now had to do with the self-interest of the physicians. I would argue that on any panel, this one perhaps, that it is the physician that most closely represents what you call the consumer, what we call the patient. Everybody else has a business model, a business to run, cost constraints, and I would suggest to you that the physician is the trusted professional on this panel. With regard to the idea that we're just looking to protect ourselves, I would say to you that there's a tremendous shift in healthcare delivery in this country, and the Affordable Care Act will promote it away from private practice and towards some institutional model, whether it's an employed physician agreement or some health system purchasing or employing physician practices. And while that may be a very efficient way to coordinate care, which I think has been shown to improve outcomes, It also needs to be offset, I believe, by the presence, even if it's a small presence, of private practice physicians. I think the private practice physician sets the ethical standard for the community. And when the last private practitioner closes his door, the employer dictates what the medical ethics are. And I think that can be potentially very dangerous. Regarding hospital systems as being the employers, my trusted friend from the Hospital Association, Kevin, pointed out about the perils of the antitrust environment, and I think he alluded to the deplorable conditions of the hospitals, the financial condition of the hospitals in New York State. There have been closures, some planned and some unplanned. Some were dictated by the Berger Commission, which was a commission set up under a previous gubernatorial administration, and it was headed by an investment banker, of all people. And people have, health policy people have noted that the Berger Commission closings and consolidations, while they do save money and promote cost efficiency, removed much of the needed elasticity in the system. I think a lot of illness, pandemic flu was something that was bandied about the last couple of years. If these unexpected conditions arise, we need to have elasticity in the system, and that needs to be planned for, and I don't think investment bankers are the best stewards of that component of our system. I think that to say that physicians are being self-serving is unfair. In New York State, we have hospitals in worse financial condition than around the country. We have stakeholders in the insurance industry that are more powerful than in other parts of the country, and I think it's very important to have the provider class, the physicians in the hospitals, to be empowered to offset those very powerful stakeholders.
And you feel that this bill does not do that remotely. It does not empower physicians. In fact, it disempowers. It takes away. Yes, no?
It's not a yes or no answer. I want it to be clear that I support the bill, my medical society support the bill, but we don't support every feature of it. And I as an individual, support things that weren't even included in the bill. The problem is that the bill does not allow the providers, the hospitals, or the physicians to have a stake in the shaping of these policies. Let me give you an example. The SGR. For those who don't know what it is, very briefly, it's a piece of legislation that reduces physician reimbursement as the cost of medical care rises. And there's a paradox there because it penalizes the success that physicians have had in treating conditions as outpatients. So the system has saved money by not hospitalizing the patients, and the physicians get penalized for it. Now you go with an idea which I think is an excellent one, accountable care organizations. It's a form of gain sharing. You're telling hospitals and physicians and other provider entities to collaborate and make better quality care, more cost effective, and you can share in the savings. The problem is who's going to get this thing started? Because it takes some infrastructure investment to promote that. You have hospitals in deplorable financial condition. I don't want to work for a boss who has no money. And you have physicians who are going to get a 30% pay cut on January 1st if Congress doesn't act. And I don't see any Congress people here, do I? The problem is that the way the accountable care organization is set up in the current legislation is the reimbursement for the physician services is based on the fee-for-service reimbursement, which will be cut 30%, absent Congress acting, plus some undetermined bonus for the cost savings. What physician is going to sign up for an accountable care organization and be the spearheader of that if he doesn't know how much money he can expect to recover from this folly? So I think when I say that I've been asked to speak opposing the provisions of the healthcare bill, I think these are some very serious shortcomings. That's not to say I don't support the bill. I can't be the person who says I don't want 50 million people to be covered.
So that's the single best thing in the bill for you?
It's best thing for everybody.
Right.
Is that anybody can get the care that they need, and when they show up in an emergency room, they're going to get a complete level of care and not get
Now,
turned.
what's the best thing for doctors in this bill?
I think there's a lot of opportunity. I can't tell you that there's any one. I think we have to be very clever about it. But I think that it's very hard. I think the best thing in the bill is that we have near universal coverage, because now we can actually take care of people. That's the best thing in the bill.
Okay, Norm?
Yeah, I need to set the record straight. I didn't say physicians were single-mindedly selfish and only,
No, that was my summary.
and only cared about themselves. I said when the physicians were thinking about their self-interest, they made a fundamental mistake. They thought that autonomy from the government would somehow be, they thought that dealing with the government would somehow be worse than dealing with the private payers, and it's turned out to be just the opposite. private payers restrict physicians' autonomy now far more than the government does in almost any system I know in the social democracies. There's also, when you talk about what's good and what's bad for physicians, there's a real generational thing, right? So I don't hang out with old physicians unless I have to. So I spend my time with students. And they've made the psychological move, to a large extent. I mean, they know they're not going to be solo practitioners. They know they're going to work for large groups. They'll probably be employed. They're much more interested in an ordered lifestyle and expanding what they do in their own lives than you know, being in charge of their own destiny. So I think it's not such a difficult selling job to the new crop of physicians that are emerging.
I come from a family of salespeople, and I don't think that medicine should be sold. And again, I share your fondness for the students. Just because they're willing to fall into this model does not make it the best policy. I want to make that distinction.
Okay, Fred, talk about the business community. You talked about some of the problems and issues. Anything good here for business? Are there elements that the business community feels are constructive?
Well, first of all, I think the point I made about communications is one that exists in more than the mind and the spirit of businesses, as per some comments that we've heard from this panel. With respect to what's good, if you look at the profile that I gave,
Overwhelmingly small business?
From a small business point of view, it's not a good thing. Because a good many of them are not only buffeted by the recession, as I mentioned before, but they're competing globally.
But won't they be able to get insurance now through these health exchanges? Isn't that good?
But you know what? They're not going to be penalized, right?
Right.
There's not going to be a penalty for those less than 50. And if I was a small business, you know what? I'd tell the employees that there are now subsidies available. And I'm sure Family Health Plus and Child Health Plus will continue to be available. So I'm not sure from a small business point of view that the impacts are that significant. If you take the businesses between 1 and 10, where Dr. Davis pointed out, 50% of those are already, I'll take the other side, don't offer health insurance. And I don't think that's a good thing. And when it comes to the 50,700,000 unemployed, which is 16.7% of the total population, this bill is only targeting 32 million. So when you say a good thing in terms of getting everybody insured or fully insured population, they're only targeting 60% of the current uninsured population.
One of the problems with that is that the recession has driven a lot more people, 10% increase in the number of people now who are uninsured. So those numbers move as the economy moves. And if the economy recovers, it may change.
They only grew 4% from year to year. The latest data being available, again being 2008. I would have thought that the increase would have been much more substantive. One could argue you might see a more definitive impact with next year's numbers, but that remains to be seen.
Okay, Kevin, and then we're going to go around one more time. We're going to throw it open, and I'd like to get Dr. Davis's response to some of what she's heard and get some other people. But Kevin, talk to us about what's good in here for hospitals. What's exciting? What's a benefit for hospitals? I know you talked about your concern, the business models, or anything in here that's a positive incentive.
Well, let me say first for hospitals nationally, what's good is whatever the number ends up being. We're going to get to perhaps 94–95% of the American citizens being covered in some level of coverage. And if the exchanges operate properly as desired, then some of those plans might be more customized to the needs of those people who get that coverage. So that's good because
no more people flooding into the emergency rooms, right? Is that good?
Well, Massachusetts has shown us something else, but
okay.
But
Well,
yes, assuming
what did Massachusetts show?
Massachusetts showed that they were successful in getting the enrollments and getting people covered, and then people access the system and find that there is a shortage of primary care physicians, and we're back to square one. And then they do access the emergency room. But let me point out that New York is different than nationally. My response would be different answering just about New York. Whereas all the states in this country now have a mandate from the federal government for the first time as to what the minimum threshold for eligibility and Medicaid will be. New York, because we've been very generous with Medicaid benefits, is far ahead of that minimum threshold of 133% of the federal poverty level. And other states who have been a lot more, shall we say, stingy or less reluctant to offer benefits are going to get subsidies to help them get there. Now, we sought a political remedy to that, and we got some tinkering done at the 11th hour, but not enough to make us conclude that this isn't entirely a level playing field. That combined with the fact that the undocumented, everybody kind of just agrees and says, well, the undocumented weren't covered in this, and that's just the way it is. Well, yeah, but they're here, and there's no immigration reform on the horizon that anybody can direct me to that would suggest that they're not going to still be here, and they're going to need some level of care, and they're going to get it at
So they're going to
hospitals.
still come to the hospitals.
But the good thing for the hospitals, in general, nationally for sure, is that these people theoretically will get the coverage that they don't have now.
Jean, you were going to respond, and I think, to what Kevin said?
Just a couple things. I think one thing that kept the ranks of the uninsured from growing as much as you might expect was because of the COBRA extension. So I don't know that lack of increased rolls is going to hold.
Sure.
The American Recovery Reinvestment Act that subsidized the expansion of COBRA had very little impact on the uninsured population. Again, lots of confusion in terms of how it was implemented, in terms of whether insurers were going to bear the 65% and the 35% going to be dealt with on tax reforms by businesses, but there's no evidence to show that that's the case.
There is actually in Massachusetts, and that's what I was going to say. There's an article in Health Affairs from last month that while there were access issues initially, those have decreased in the most recent data with people reporting difficulty accessing care. So I think with an initial bulge of individuals eligible for health care, that's turned around. And they thought that despite the recession, they were able to maintain where they were relative to other states, was partly because of COBRA extension as well.
Okay, one more question quickly. We'll start with Ruth. Let's deal with this issue of communication, which everyone seems to agree that there's a great deal of confusion, and among business people, they don't have a good sense. I don't know whether doctors and other people really, your experience that everybody's getting information. What's the give me something concrete we can do to improve public education on this issue. If you could do anything you want, what would you do?
Take Don Berwick's advice and stay united and stay the course, and try to develop some very simple, practical messaging. I would put Dr. Davis in charge of it. She always makes everybody understand the legislation for a minute while they listen to her, that is available to consumers, physicians, hospitals, businesses, and the academic centers alike, none of which will answer all their questions, but will give you enough of a headline and a resource place for more information that isn't widely and universally available. And when it is, it's not giving the same message through different locations. And if it were, it would be very helpful.
Lots of organizations have put out, Dr. Davis's organization put out lots of information about the healthcare reform. You can go on dozens of websites. The government has a website that walks you through frequently asked questions. Why isn't the messaging getting through, Gene?
There's a lot of fear of the unknown because things are changing.
And it's
People
going to
like
be a
hang
long
on to what
time
they
frame
have.
before we understand what's going to really happen.
Correct.
Right? There is
There's a
uncertainty.
delayed effect for a lot of things. I think a lot of people aren't aware of things that have already gone into place, like pre-existing condition insurance programs in the states that are already in effect. Children being allowed to remain on until 26, things like that. I think that there's a lot of money behind some of the negative messaging, and that's getting out there, and fear of losing what they have, which in the case of seniors, is not really.
Seniors have a more
Yes.
unfavorable view of
Right,
what's
although-
happening because of the concern, as Dr. Davis said, their fears about Medicare and their misunderstanding. Charlie, are the doctors well informed? I know I'm making a broad statement. Do they understand this bill, the people you talk to?
Absolutely not.
They don't, and they're the
there's
doctors.
Conflicting, yeah, and I think that they feel like the public does. They're divided on it. I think that everybody drills down on one provision that they don't like, and they extrapolate that sentiment to the entire bill.
So the people who are the most knowledgeable about patients, in your view, don't understand the bill? The doctors?
That's a fair statement.
And is it because there's a cognitive dissonance, the people who are opposed don't want to understand it, or is just the lack of communication and information?
I like James' concept of counter-messaging. I think that the payers, there's always a villain in every story, and I think the payers are the villains here. I think they have a tremendous stake in this, in terms of they control all the money, they control where it goes, and they want to protect that stake. They're the big winners in healthcare reform. You didn't ask me that question. They got 30 million new customers.
Right. But the doctors don't have access to reliable information that they can...
They do, but the doctors and the patients themselves bring in this frightening information, stuff a little less frightening than death panels. But the reason why seniors are afraid is because they have the most to lose.
But why can't doctors explain to their patients what's happening?
Because they don't know what's happening. So much is yet to be determined. What we hear about is IPAP, and that's a frightening prospect to doctors.
Okay. Kevin, your thoughts about communication?
I'm going to put my lobbyist hat on, representing hospitals, admit my bias, but also just say, look, we have to recall that this piece of legislation was negotiated in a year in which there was a heck of a lot else going on in this country, in terms of having to come back from what was nearly a complete implosion of the financial services sector. The administration having to deal with the auto industry. This all gave fuel to the fire of those that would suggest that we were encountering too much government in our lives. And so I think that this got caught up in that. We heard about a series of presidents in our past who tried to advance something like this and didn't even hardly get out of the gate. In retrospect, I think that I know the Obama administration made a calculated decision this time around. You look back at the Clintons' experience. The Clintons' approach to healthcare reform was to go off and meet with consultants and experts in the field and come back and hand Congress a book and say, we think this is the way you may want to think about doing it through managed competition. This time around, President Obama really stated it as his #1 domestic goal, but asked Congress to do the work. And the result of that was, I think, Dr. Davis, we had 5 committees of jurisdiction between the 2 chambers in Congress that ended up with various versions of this bill. That created a hell of a lot of confusion. And so that combined with, look, the social networking that we got going on, the way in which people's opinions are being impacted these days is a lot more, on one hand, subtle, but on the other hand, a lot more intensive. And so I think we've got to remember that context.
Okay, Fred, what would you do to improve communications, even to the business community? What's the single most important thing or something concrete you would suggest?
Well, let me first say that 2014 is a long way off, and obviously there's some time. There needs to be a lot of regulations formulated so that, while I would suggest the following, we need to be careful about a good many of those regulations that HHS is focusing on. As many as 700 or 800 pieces of regulations associated with issues I'm talking about. But you need to do a grassroots effort. It needs to be non-political. I don't believe...
Who should take charge of that?
I think that should be somebody in conjunction with the government and the business community. For example, Chamber of Commerce is a good way to get the word out to businesses, but they need to have that information. That information has to come from somewhere. It probably has to come from the federal government. And then disseminating it has to go through a number of distribution channels from a communications point of view, not the least of which is the internet. The internet's very powerful here. I'm surprised that you would draw the conclusion that media-based contra communication is just so overwhelming that people can't see the forest from the trees. There's so many different ways today people can get information. I think clearly the issue is this is very complex and very little time has been spent by anyone rolling it out to the business community. People like Dr. Davis and people on this panel who have spent a lot of time reviewing the legislation have managed to do it only because of a lot of hard work and having a base of understanding to begin with. So to answer your question, I think there needs to be a proactive communication system that co-ops the business community, primarily through Chamber of Commerce's and business associations, but it needs to be incessant.
I got you. Charlie, before we get to Norm, quickly.
I take strong exception to the Chamber of Commerce being the agent here. The Chamber of Commerce has a well-established political agenda.
I'm not talking about the U.S. Chamber of Commerce. Okay. I'm talking about local Chamber of Commerce.
Okay, Norm, last word.
Well, the problem is really substantial because, as many people have pointed out, communication is best done by concentrated, wealthy interests. And, you know, the payers, the insurance companies are just that. And as several people have pointed out, they are generating, either directly or indirectly, a lot of the negative communication. The problem is in my opinion, is in the timing of the legislation. So the givebacks of the insurance companies cut in soon, have cut in. But the payoff to the insurance companies is not until 3 or 4 years when universal coverage is mandated and all the new business kicks in. So there's a dissonance. And 4 years in the life of an insurance executive is really large. So how do you deal with that? Well, you can't change the law. What the federal government is doing now, probably reluctantly, is making concessions to the insurance company. So, you know, the regulations of no limitation on yearly or lifetime benefits, several, I think 20 or 30 exceptions have already been granted. The most visible is McDonald's. McDonald's said, hey, you know, we can't do that. We're just going to walk away from health insurance. So in order to deal with the vociferous negative communication of this powerful interest, I think what the government has decided to do is make concessions until their rewards kick in. That may not be an ideal solution, but I think that's what's happening.
It's very refreshing to me. I'm going to ask Dr. Davis to come from it. It's very refreshing that this is the first time I've been on a panel like this and no one's attacked the news media. So I feel good about that. It's always been the news media has been the key problem in communication. Dr. Davis, could you just give us briefly your comments and reactions to anything that you've heard on the panel?
Well, I think it's been a terrific panel, a very thoughtful panel. It's kind of not what you're hearing in the national debate with a lot of rhetoric and extreme allegations, but people are really grappling with it. So I thought my takeaway were it was all done in the sense of health reform is the law of the land. So what does it mean? How do we deal with it? Where do we go from here? We didn't hear somebody jump up and say repeal, defund. So it is, in fact, the reaction I feel like I'm getting as I go around the country, that people recognize that change is coming. Having said that, one thing that came home to me is just how precarious everything is right now because of the economy. It's precarious for business, it's precarious for healthcare providers, it's precarious for American families. So when small businesses are worried about still being here, when physicians are worried about paying their malpractice premiums, you know, this is the context in which this is coming, and would have been there without the reform law, but that kind of makes it very hard to deal with it. So what came across is, as these last points came through, is that people still don't understand what's in there, and then understanding it, there's a lot of uncertainty or fear about how to respond to it. I love the point about you don't want to be too soon and you don't want to be too late. The issues of antitrust, you don't know what the rules are and whether the government's speaking with one voice about what's legitimate in terms of care coordination or seeking better integration across services, concerns about the accountable care organizations where you may have some upfront costs and some downstream, way downstream shared savings of unknown magnitude that's troubling as well. And then I thought it was very interesting when you pressed them on what's good about it. In the end, it was the universal coverage, or the near universal coverage. And I think everybody recognizes we just couldn't stick with what we had before, and that's going to be good. It's going to be good for families, it's going to be good for businesses, it's going to be good for the healthcare sector. But there's less understanding of the cost and quality provisions and a concern that we don't really have a magic bullet that will, in fact, improve quality, have better access, and yet somehow manage to do all of that at lower costs. And I think that will be the real challenge going forward, is can we do something that really works, that simultaneously achieves those three goals of better access, improved quality, and greater efficiency. So thank you very much for being
well, thank you, everybody.
part of this.
As a journalist, I'd like to meet our deadlines. We could talk about this for weeks. We probably will. But we are out of time. I want to thank all of you for coming today. I hope you enjoyed it. Will you please thank the panel with me?